We are on Unit 9, Part 4. This is the last part of pregnancy at risk or high-risk pregnancy. And I'm calling this section of content, sort of our odds and ends section. It's like a little bit of a catch-all. We have a little bit of this and a little bit of that. We're covering hyperemesis gravidarum, which is a condition that some women get during pregnancy. It's not your typical morning sickness or nausea and vomiting. It's sort of that morning sickness taken a step further into something that's more pathological. We are going to cover certain infections during pregnancy. In particular, we're going to talk about the torch infections because they have serious repercussions for pregnancy. And we're going to talk about HIV. We're also going to talk about preterm rupture of membranes, which is when the amniotic sac breaks prior to the beginning of labor and while the fetus is still preterm. We're going to talk about incompetent cervix, which is a premature dilatation of the cervix. And we're going to talk about multiple gestations. And remember that multiple gestations are not, twins aren't a disease. However, they do raise mom's risk factor, twins and higher order multiples for other diseases and other issues. And those fetuses will also be at risk. So that's, sort of what we're covering in this section of content. Hyperemesis gravidarum refers to a severe form of nausea and vomiting in pregnancy. Nausea and vomiting is common. It's about 70 to 85% of women will experience some queasiness and occasional episodes of vomiting, but this is a severe end of the spectrum. And it's usually accompanied by ketones in the urine, so ketonuria, which is a measure of starvation. When your body's not getting enough carbohydrates to make glucose, it will start to break down the fats. Part of that is you're going to get an acetone molecule as part of that process, and those ketones will spill into the urine. So that's your ketonuria, and that tells you that mom's not holding down enough food to provide glucose to her brain. So there's that. We're also going to see weight loss. It's going to be 5% on average, but it could be more. And certainly if a mom is losing that much weight at a point where she should be gaining that in the first trimester, 1 to 4 pounds, and then 1 pound weekly after that, this is something we might want to be concerned about. Hyperemesis is one of the main reasons that we do hospitalize women in pregnancy. It's probably the most common admission for early pregnancy. There's very few things that we hospitalize women for in the first and early second trimesters, and this is one of them. Let's talk about some risk factors. So risk factors. First-time moms, your primips, more severe, probably because their bodies are acclimating to the hormones. Obesity, women who are obese have imbalanced hormones typically, and that can be a factor. Multiple gestation, because the amount of HCG that circulates in your blood is going to be higher. Gestational trophoblastic disease, those molar pregnancies, have a higher incidence of hyperemesis. I'm sorry, let me finish that sentence. Other risk factors, previous pregnancy. Not always, but many times a woman who has had hyperemesis gravidarum will have it in a subsequent pregnancy. So there's that. And we also have first-degree relatives. If your mom, your sister, your first-degree relatives have had a history of hyperemesis, you're more likely to get it. And another risk factor, which I thought was interesting, was migraine headaches, and that probably has to do with the vasodilation effect. But those are your risk factors for hyperemesis gravidarum. Now, one thing that I would like to point out is that there have been some qualitative studies done on women who have experienced pregnancy with hyperemesis, and it does really impact their ability to enjoy their pregnancies and to attain the maternal tasks of pregnancy we talked about in psychosocial adaptation. So it's definitely something we want to address. in addition to the physiological needs that are created when a mom is dehydrated and has, can't keep food down. So, medical management. What do we do for moms? IV fluid. We're going to rehydrate that mom. And the sad part of it is when they come in, they usually have really flat, dry, spidery little veins because they're so dehydrated. But we have to get that fluid in them, and we have to sort of maybe keep them from going into ketosis, and part of that might involve some dextrose, so you might see D5W. Now, if mom's in the hospital and she hasn't been tolerating food, we might keep her NPO for a little bit, just to sort of give her a rest from that vomiting. When she does stop vomiting, we can give her a bland diet, saltine crackers, dry cereal, toast without butter, anything she'll really tolerate. And as she gets a little bit better, we can start to move her towards a more nutritious diet. But in the beginning, we're just going to get some calories into her and get some carbs into her, and get her those foods that she can tolerate. Now, as far as the natural things, we can do ginger. Has been found to be effective. It's not necessarily under medical management, but it is an alternative treatment that we can recommend to moms, and it's safe during pregnancy. And vitamin B6. Vitamin B6 is also a very useful and safe treatment to give to mom. Now, we might give medications like ondansetron, which is Zofran. And I caught the autocorrect before it bit me. And that's one of the meds that you wanted to make your med templates on. We do give this during pregnancy. It's always a risk versus benefits, and it has been found to be generally regarded as safe during pregnancy. And another thing we might give is metoclopramide. That was going to happen. Also known as Reglan. And this is also going to help mom with the nausea and vomiting. And it's going to move the gastric contents through the GI tract a little bit faster so that she doesn't have big boluses of food sitting in her stomach making her nauseous. We might give TPN. If the dextrose isn't enough, and if we can't get her to eat a little bit more. And I have seen them give lipids, TPN, and that's sort of a separate topic that we talked about under nutrition. Once mom is tolerating food, we're going to try some high protein snacks, and we're going to teach mom to avoid foods that are irritating, foods that are spicy, foods that are greasy, foods that are fried. Anything with a strong odor to it or a strong flavor to it is usually going to be out of the question. But those are sort of some of the things. Let me make it smaller so you have a list there that you can look at. Those are the things that we would do for mom. Now, you also want to make sure that mom is getting her vitamins, and that might have to happen in an IV form if she can't tolerate her prenatal vitamins orally. You might have to time the prenatal vitamin, if she can swallow it, for a nighttime dose. But those are the kind of things that we do for hyperemesis gravidarum. We definitely want to monitor this baby for growth if this continues into the second and third trimester. So ultrasounds to chart fetal growth. Definitely if mom has any other lifestyle factors that might aggravate her hyperemesis, for example, If mom is a cigarette smoker, if she drinks alcohol, if she does anything that could predispose her to more intense vomiting, we're going to counsel her to stop those things. So we're going to begin our discussion of infections during pregnancy by talking about the torch infections. And torch is an acronym that stands for toxoplasmosis, which can cause mental retardation in the baby. It is a mild infection that most people are immune to. However, pregnant women is immunosuppressed. The common way that we get toxoplasmosis infections is by either handling cat litter or feces or consuming undercooked or raw meats. And so the woman who has cats, indoor, outdoor cats in the home, should be counseled not to change the litter. And if she has to change the litter, to use gloves and not handle those feces directly and wash her hands directly after. So that is toxoplasmosis. The O stands for other infections. And by that, your book really refers to hepatitis B as being the most prevalent one. There are, many other infections that could come under this umbrella, but you should probably focus on hepatitis B. Hepatitis B is a serious bloodborne illness that leads to chronic liver disease and in some cases liver cancer. And without treatment, there's a 90% transmission rate to the infant during delivery. The way that we handle it, we identify moms early in pregnancy. We test for the hepatitis B surface antigen, and that should be familiar to you from Unit 8, antepartum. If mom is identified as a hepatitis B carrier, our plan is to vaccinate and give immunoglobulin, or HBIG, hepatitis B immunoglobulin, to the infant as soon after birth as possible. The HBIG really should be given within 12 hours. And the hepatitis B, I've seen different protocols, but the sooner you can give it, the better. You do not need consent in the state of New Jersey if the mother's hepatitis B positive. In all other instances, you do need consent for that vaccine. You also need to report it to the state because the state tracks these infections in newborns. If an infant acquires hepatitis B, they have a 25% chance of developing serious liver disease, and the prognosis for that is very poor. And so this is something that you want to identify and treat if at all possible. It's really unacceptable to miss that. If you don't know mom's hepatitis B status, for example, she came in no prenatal care and you couldn't get a titer on her or you couldn't draw a surface antigen test, you follow the protocol as if she were hepatitis B positive. Our next infection, the R, is for rubella, and rubella is also known as German measles. It is a vaccine-preventable illness. However, some people do not make antibodies when vaccinated. We depend on herd immunity to protect us from this one. Another reason you want to educate your patients about vaccines. Rubella in particular was targeted by Dr. Wakefield in the UK as being implicated in causing autism. And a lot of parents bought into it. And even after that study was torn apart, he made up his own data. Even after many other studies proved that there was no connection between rubella vaccine or MMR vaccine and autism, you still have parents who go on the internet and they are terrified of autism spectrum disorders, especially if they already have one child on the spectrum and they know what they're dealing with. But we need to educate patients that the rubella vaccine is safe. It is safe, except we don't give it during pregnancy because it is a live virus. So that's another thing that you should know about the rubella vaccine. Congenital rubella, if you acquire rubella through the placenta, and I have seen cases of congenital rubella, can cause deafness, blindness, mental retardation, and cerebral palsy. So it's definitely something we want mom to understand. If she comes into the pregnancy and we test her and she's rubella non-immune, then immediately postpartum she should be given that vaccine, that MMR vaccine, to try and protect her future children from congenital rubella. If there are any rubella outbreaks, usually a public announcement goes out and pregnant women are advised to not have contact in places where they might encounter rubella. The next virus or the next infection on our list for the C, we have cytomegalovirus, and CMV is very common in daycare centers and with small children. So, of course, this is our population. Hopefully, mom has been exposed to CMV in the past and is immune. CMV can cause mental retardation in the fetus. And so if mom is, say, a daycare worker and this is her first pregnancy, you might want to get a titer. CMV also affects women with HIV and, well, anybody with HIV because they're immunosuppressed. Most people who are exposed to CMV as an adult will not show any symptoms. If you are exposed and you're immunosuppressed, you may have flu-like symptoms. But that's something to be aware of. It is a common cause of mental retardation. And then we have the herpes simplex virus. And herpes 2, HSV2, is a sexually acquired disease or a sexually transmitted disease. What we do for this is if we know that mom has HSV, we will prophylax her with some Valtrex. I'll put that down there. Don't know that you'll see it again. To suppress any kind of infection if we're planning a vaginal delivery. Herpes lives in the nerve ganglia, and at times of stress and inflammation, especially during childbirth, it can predispose a mom to an outbreak. Fetuses or newborns who have been exposed to herpes can actually get very, very ill. They can get, a skin infection, which, is serious, but they can also get infections because it is a disease that hides in the nerve ganglia. They can get encephalitis and other neuropathies. And I have seen a case of herpes encephalitis, and I can tell you this child had seizures almost nonstop and was severely, profoundly retarded. At 17 months old, he was still in a crib, could not hold his head up, couldn't sit up. So this is something, again, that you want to be careful with. If mom presents in labor with active lesions, the mode of delivery is almost always going to be C-section. So these are your torch infections, and they tend to show up on NCLEX questions and things like that. They're the traditional ones. Now, under other infections, in the future, you're going to probably see a lot of reference to things like Zika virus, Z-I-K-A, but there's not enough information on it right now for me to present and give you anything meaningful. It does cause birth defects, including anencephaly, and there have been outbreaks in certain parts of the country, including Brazil. So it's something that you may see more literature on, but not covered for this content. Next, we're going to talk about sexually transmitted diseases. In addition to herpes, there are a few that impact pregnancy, and bacterial vaginosis, which is just a vaginal infection. Chlamydia and gonorrhea are very, very common in the young adult population, and they can cause some serious problems with pregnancy. Both chlamydia and gonorrhea can cause a conjunctivitis in the newborn. It can be acquired through the birth canal. And that can lead to blindness. So this is sort of a serious thing that we want to keep track of. If mom culture is positive for either one of these diseases, we want to get a test of cure. And as a routine measure, every baby, unless mom refuses it or dad refuses it, will get an eye ointment that contains erythromycin that will prevent that. So it's important to try and get that in within 1 hour. Now, the protocols have changed somewhat in that with baby friendly, a lot of parents want to bond with their newborns, and they don't want that thick ointment in their eyes because they believe it obscures the newborn's vision, which the newborn's vision is not that acute at that age, to be honest. But just to encourage and facilitate bonding and to acquiesce to parent wishes, if mom has not tested positive for chlamydia or gonorrhea, we can delay that sometimes for 2 hours to allow them skin-to-skin contact and bonding. But then we want to get that eye ointment in. So that's chlamydia and gonorrhea. Now, chlamydia also has the additional impact. It can cause pneumonia. And so what we're going to do is kind of watch this baby. But when we treat one partner, we want to treat all of mom's partners. Hopefully, dad is willing to go ahead and get treatment. And certainly if mom has multiple partners, we want to encourage her not to engage in that behavior during her pregnancy and to use condoms if she is. I mean, we've had patients who are sex workers, and you really have to do extensive education with them and tell them about the risks of sexually transmitted diseases and encourage them to use condoms when they're out. So that is chlamydia and gonorrhea. Trichomonas is another infection. It can cause like a foul-smelling yellow-greenish discharge. The big thing with trichomonas is that it can cause preterm labor and preterm rupture of the membranes. And preterm rupture of membranes is something we're going to talk about a little more extensively. Here, let me just kind of make a note of what trichomonas does. Oops, sorry. trichomonas can cause preterm labor. It irritates those amniotic membranes, and it causes this low-level inflammation, and it can also cause chorioamnionitis if you do get rupture of membranes. So let's kind of move that. Oh boy, Carrizo at noontime. No, we don't want that. Sorry. Autocorrect strikes again. I wasn't on top of that. Okay. And it kind of cut off some of my words, but you get the point. So this is something that we definitely also want to treat. And the same thing holds for bacterial vaginosis. Bacterial vaginosis isn't necessarily sexually acquired. It can be just a vaginal infection. But the key to bacterial vaginosis is that you're going to get that fishy smell that we can do what's called a whiff test. You add potassium hydroxide, or KOH, and you'll get a very strong fish-like odor. And we want to treat this because, again, it causes preterm labor, preterm rupture of the membranes. And if we have a very significant bacterial vaginosis, or BV, we can also sometimes see chorio if mom ruptures and it stays ruptured for a while. Okay, and our last is syphilis. Syphilis is never really gone away. It's quieter now. I think for a while I remember having a nursing instructor back when I was a student who said, oh, it was almost like we eradicated it and then it came back. We do sometimes see cases of syphilis in pregnancy where I work. And the only effective treatment for syphilis is penicillin. Okay, and so if you have a mom who's allergic to penicillin, what we actually do is sort of desensitize her in the ICU, give her tiny, tiny bits of penicillin, and then increase the amount, titrate it. You do it in the unit in case she goes into anaphylactic shock. You want to respond quickly. But we really need to try and treat her with penicillin because congenital syphilis is a very serious thing for a baby. And, it can cause severe, severe brain damage and other problems. So those are your sexually transmitted diseases with the exclusion of HIV. Sorry, let me bring that back for a minute. I just want to get rid of that. I don't want to get rid of the heading, so because I'll forget what I'm doing. So we're going to talk about HIV. And HIV is a really important disease to understand when you deal with the pregnant population because the fastest growing segment of new cases is heterosexual women, and they're being infected by partners or through IV drug abuse. We are now testing all pregnant women, or at least offering that test. They can refuse it, though few do, and when they do, we sort of worry about what's going on with them. We test pregnant women in the first and third trimester, assuming they come for care. If they present with no care or late to care, then we just do one in labor and delivery, or they'll do one at the first prenatal visit whenever that occurs. If it's in the third trimester, that will be the only one they get. If it's somewhere in the second, like say at, 23 weeks, then they'll get it twice, first prenatal visit and then somewhere in their third trimester. Usually when we do all their glucola and their, all their other screenings. Okay, so it is important to understand how HIV works. Now, it is a retrovirus. It is transmitted through blood and body fluids. And we didn't used to test for it routinely. Now that we are catching a lot of new cases. And we don't know how long mom's been infected, but we do know that she's having unprotected sex because she's pregnant and she is testing HIV positive. So what we worry about with HIV, of course, is neonatal transmission. And so during pregnancy, we're going to do antiretroviral therapy. And there are agents that are considered relatively safe. Nothing is 100% safe, but strictly speaking, in a risk versus benefits perspective, it is much safer for the fetus to receive the antiretroviral therapy than it is to take a chance on neonatal transmission. If we can get mom's viral load down, the risk of transmission is very low. We can lower it to less than 1%. And so this is a goal of therapy. So our goal, and I'm just going to repeat it, is to reduce the mother's viral load. And our goal for that is less than 1,000 copies of the HIV RNA. So without treatment, the transmission rate to the neonate is 25%. And as I said, with therapy during pregnancy, we can reduce that transmission rate to 2% or less. And I have seen numbers that suggest that 1%, particularly if we use that 1,000 copies as a guide to decide which mode of delivery. If mom has a viral load of less than 1,000 copies, it's considered safe to deliver vaginally. And if it's above that, we really need to consider a cesarean section, because the cesarean is really the safest way to deliver the baby. Even though there's more maternal blood loss, it's more controlled, and the surgeon can really make sure that the newborn doesn't get any scratches or cuts. Oh, sorry, I need to finish my sentence there. But that's sort of a decision-making guide that if mom has more than 1,000 copies of that HIV RNA, we're going to try and deliver that baby by cesarean section. It is the safest way. And you would counsel your moms, most women don't want C-sections, that this is really the safest thing for their babies. So when we're talking about how this virus is transmitted, and that's important to know, it can be transmitted through the placenta, although that is the least common, sorry. And that's one goal of our antiretroviral therapy during pregnancy, is to reduce the rate of infection through the placenta during delivery, so intrapartal. That's another mode of delivery, mode of transmission. And that's one of the reasons that we were talking about whether we deliver by vaginal method or by cesarean. The other consideration with that is we want to make sure that we're not doing anything invasive that we don't have to. So we want to really use external fetal monitoring if we can. We want to use external tocodynamics. We don't want to introduce that, and you'll see it when we talk about labor, the internal scalp electrode, the internal fetal monitoring, we want to try and avoid that. And we don't want to try and use that intrauterine pressure catheter. It's just not an appropriate thing to do. Certainly at that point you wouldn't want to use when you rupture the membranes, you want to be very careful not to scratch the baby's head. And many doctors will avoid using forceps or vacuum for that reason as well. You don't want to do anything that would break the skin integrity and make that baby more susceptible to that virus. The next method of transmission that we can talk about is through the breast milk. So these mothers are advised not to breastfeed. And the main treatment for HIV during labor is going to be a medication called zidovudine, also known as AZT, and that's how we commonly refer to it because it's easier to say. We're going to hang this during labor. There's a standard protocol for the order, and it will reduce that risk during the intrapartum period. Even if mom has a viral load less than 1,000 copies, and if her CD4, we'll talk about that, CD4 is another measure of this illness. If her CD4 is normal, there is still a slight risk that her baby could be infected during the delivery process. And so we hang AZT and we avoid all those invasive procedures that we just talked about. AZT will also be given to the newborn following delivery. So if you're working in the newborn nursery, you may see babies that are treated with AZT. And that comes as an oral suspension for them. It's a little liquid. You drop it in a syringe, and actually, pharmacy should send it up to you because it's weight-based dosing. But that is how we deal with HIV in pregnancy. Our next topic is preterm rupture of membranes, and that refers to the rupture of the amniotic sac prior to 37 weeks gestation. Most of the time, membranes rupture either just prior to labor or somewhere during labor, but they can rupture in 10% of pregnancies before labor begins. When this situation happens before the woman is 37 weeks, which is what we consider to be term, we have a problem known as preterm rupture of membranes. The causes for this, sometimes we can't really identify a cause, but sexually transmitted diseases or bacterial infections of the vagina. And we talked about that in this presentation a little bit ago. Cause that low level of inflammation. Smokers, don't know why, but I'm guessing. I've never seen any literature that says why this is true, but you have that low level of inflammation, and you have kind of probably poor vascularization of the uterus. And we get anything that over-distends the uterus or creates more fluid. So polyhydramnios. And if you remember all the way back to diabetes and pregnancy, that is a risk factor for polyhydramnios. So if you're, it's like a balloon. If you keep overfilling it, eventually it bursts. Multiple gestations. Sorry. Okay. Twins, obviously you get that hyperdistension of the uterus. And any previous history of rupture of membranes. So next we need to talk about the risks to mom and baby, and the big risk. If you remember nothing else about PROM is infection. Okay, moms can get septic, and I'll tell you my PROM story, which ended up being a DIC story after we're complete with this. But you can get maternal or fetal or neonatal sepsis. It is usually a very rapid infection. It can usually make moms very sick, and babies can die. So sepsis is the big one that we want to watch. Now, obviously, preterm delivery. In most cases, when you rupture your membranes preterm, labor will follow within about a week. It's one of those things that it sort of creates... sometimes there's an underlying mechanism that's causing both, but it also creates that environment where the uterus is getting signals from the brain and other parts of the body that it's time to evict its tenant. So in most cases, you will have a preterm labor. If mom goes into labor with a rupture of membranes, I have never seen them try to keep her pregnant. It's too risky for baby, for mother. They just go ahead and deliver. I mean, you try to get your steroids in and stuff, but just so you know, that don't try to tocilize a mom who is contracting after her membranes have ruptured. It's just too high risk. Okay. And then we have an increased risk of cesarean birth. At some point, it might be advisable to deliver this mom, and she might not go into spontaneous labor. If that happens, they will perform a cesarean. So that's some of the risks to mom. Now, of course, the baby has all the risks of what a preterm infant would have. Additionally, if she stays ruptured for a long time, we have the risk of hypoplastic lungs. Because remember, I think we talked about how the baby's breathing efforts, they're breathing in amniotic fluid. That helps them expand their lungs, and it helps their lungs develop. And that exposure to the chemicals that are in the amniotic fluid sort of help the lungs mature a little bit better. So if baby's in this environment where there's been no amniotic fluid for a long time, you're going to get hypoplastic lungs. Now, here's the thing. The mother and baby will continue to make amniotic fluid, but if she's grossly ruptured, it's going to leak out as fast as it was. So you're looking at less amniotic fluid. You're also looking at increased risk cord compression. What were some of the functions of amniotic fluid? It cushions the cord. The cord is the baby's lifeline. So if you don't have fluid, there's an increased risk that there's going to be pressure on that cord. There is also an increased risk of a condition called cord prolapse, a condition that we will talk about more when we talk about intrapartum at risk. And this is when the cord presents before the baby, and this is a life-threatening situation for this fetus because the fetal head or presenting part is going to put pressure on that cord and obstruct all blood flow. Additionally, if the cord is out of the vagina, the Wharton's jelly starts to dry up and you'll get vasoconstriction. If you try to manipulate that cord and push it back in, you'll cause vasospasm. In any event, it's a very serious situation and you would need to deliver that fetus immediately. But we'll talk about that more in labor and delivery. Like I said, everything with OB, I feel like there's 6 degrees of separation. You start talking about one thing and you end up talking about something else, but we'll try to minimize that for time management purposes. But these are all the risks of preterm rupture of membranes. Okay. So the way to diagnose preterm rupture of membranes, typically when a woman comes in, she'll state that she has leaking of fluid from her vagina. And this is why it is so very important to teach women warning signs in pregnancy. There are women who have come to us and said, well, I first started noticing it last Thursday, and now there's a big gush and there's some blood and I'm crampy, or I have a bellyache, or I have a fever. And you're like, oh my gosh, you've been ruptured for 4 days and we haven't been able to take care of you. You need to let moms know when everything is going swimmingly and they're fine and they're not experiencing symptoms, that vaginal leaking, bleeding, decreased fetal movement, all of these things are totally abnormal. Particularly, until you get closer to labor, leaking of fluid just means you're ruptured, and then you can, if you're 39 weeks, it's not a dire prognosis, it just means you need to come to the hospital. But if you're 18 weeks or 25 weeks, that leaking of fluid is really, a danger sign. So moms need to know about that. When we do see mom in OB triage, we're going to get some things ready for our provider. We're going to get speculum. We're going to get slides so that they can test for ferning, and I'll talk about what all that is. And we're going to get nitrazine paper. So we're going to test the pH of this stuff that's leaking out of mom. Everything must be strictly sterile. Gloves need to be sterile for the provider. The speculum needs to be sterile. You need to really not introduce any bacteria into the vagina that isn't already there. The vagina is loaded with bacteria. It's not a sterile area, but inside the uterus, inside the amniotic sac, should be sterile. So you're doing a sterile spec exam. You examine for what's called pooling, and that's just you look and see is there any fluid pooling in the vagina. And if so, what kind of fluid is it? If it's like mucousy, that's a little bit different. If it's real watery, that's very suggestive of ruptured membranes. Ferning. Ferning reveal... let me get a picture of ferning, because that'll make it a little bit more clear. Hold on one sec. Okay, there we are. This is a positive ferning test. And you can see inside the fluid you have these little branches that look like fern leaves. That is considered one of the most reliable diagnostics. You won't have ferning if you're not ruptured, typically. But it's important, make sure that you have the slide and the cover slip so that the doctor can, or the midwife, whoever's managing, can look at this under a microscope and look for that sign. Positive nitrazine. So we get our paper. It's this little litmus paper. And it turns blue in the presence of amniotic fluid, but it can turn blue in the presence of other things. So if you're touching it to the pad and you get a blue result, it could be urine, it could be any kind of discharge. you really need to sort of get that nitrazine from the vaginal fluid that's leaking. And the best way to do it is to allow the provider to do it when they're doing that sterile spec exam. You can also use a sterile glove and kind of do a little bit of an exam on the outside of the vagina. You really don't want to be poking around up there. The next test, if you do an ultrasound, you should see oligohydramnios, which is because the fluid is all leaking out of the vagina. You might have to do serial ultrasounds to see if there is less fluid with every day. Sometimes if you have like a slow leak, you can still have amniotic fluid, but it will be decreasing every day. So how do we manage preterm rupture of membranes? Or how does the medical team manage preterm rupture of membranes? Well, if that baby is considered pre-viable, if we're looking at a fetus that is less than 23, 24 weeks, 23 weeks is really, really iffy. And I know that you might have read or heard 22 weeks is considered viable. I have never once in 14 years ever seen or heard of a 22-weeker who has survived that kind of preterm birth. 23-weekers, we've had a handful that have made it and done well. We've had many more that have not survived. But so at 23, 24 weeks, we can start to talk about viability. If that fetus is pre-viable, mom ruptures at 18 weeks or 20 weeks or 21 weeks, we deliver. We do not take a chance that mom is going to become septic and die. It does not matter if the fetus has a heartbeat. We're not going to wait the 2, 3, 4, 6 weeks to wait for this mom to become septic. So typically we'll do a cytotech induction, which is sort of a topic for another day. But cytotech is a medication that will act even on a preterm uterus that isn't responsive to Pitocin necessarily. So that is the plan when they are pre-viable. When you have a mom who is past 34 weeks, you deliver because that baby is mature enough that the risks of staying pregnant outweigh the benefits to any kind of lung maturity. So risk versus benefits, if they're over 34 weeks, you deliver. You don't hang around and wait. You're not going to give steroids at that point, so there's no point. Now we have 24 to 32 weeks. So we've taken care of the really early ones and the ones that are almost cooked. There's this whole in-between category of 24 to 32 weeks. And then we'll talk a little bit about 32 to 34 because that gets a little sketchier. Generally, we don't want to make a preemie if we don't have to, but we don't want to keep baby in a hostile environment and we don't want to expose mom to the risk of sepsis. So we are going to do what's called expectant management. And I'm going to discuss that as a concept once we discuss how we approach things. You sort of watch and wait, and you look at labs, and you look at fetal monitoring, and you administer antibiotics, and you administer steroids. When something changes, baby doesn't look reassuring on the monitor, mom spikes a temp, white count goes up, there's any signs and symptoms of preterm labor, get the kid out. That's what we do. Until then, we manage expectantly. So we give the baby enough time to mature while we watch for, like hawks, for any single little sign or symptom that infection is brewing. Once we see, or that the baby is not tolerating the lack of amniotic fluid, and then we deliver. Okay? Now, 32 to 34 weeks. This is sort of one of those gray areas, and it probably depends on which doctor's managing or which practitioner's managing, and where you work and how well equipped they are to deal with preterm babies. If you're in a level 3 NICU, they may decide to go ahead and deliver at 32. Again, the longer that the fetus stays in mom, given that mom's a good environment for that baby to be in, the better. But at 32 to 34 weeks, we might get that LS ratio that we've already talked about. And if it's 2 to 1 and we've got enough fetal lung maturity, the trend is going to be towards delivery. So that's where your LS ratio plays in. When you're trying to make a decision, is baby better in or better out? And, risks and benefits look almost equal. That lung maturity, that LS ratio might be your tiebreaker. Or you might just have a doc that says, let's keep an eye on her just like we would at 32, 31 weeks and 6 days. Let's just keep an eye on her. When something changes, we'll move to deliver like that very minute. It just sort of depends on your practice environment, which decision is going to be advised. And a lot of times the person who makes that decision won't be the OB, it'll be a perinatologist who works with maternal fetal medicine if you're in a place that utilizes that service. Okay, so more medical management of preterm rupture membranes. Typically, we're looking at antibiotic therapy. The agents of choice, if mom has no allergies or there are no other contraindications, are amoxicillin or ampicillin and erythromycin IV, and then we convert to PO, amoxicillin, erythromycin. And that's a very standard protocol. We're going to do a CBC at least daily. Sometimes I've seen them do it every 12 hours if they're really vigilant. And we're going to look for elevations in the white count. Remember, mom's white count could be elevated during pregnancy slightly anyway, but we're going to look for a trend. Now, the white cells will go up if mom gets septic, and this is sort of something that you should be covering in other areas of nursing outside of OB. But one of the signs of sepsis, you'll get this elevation in white count, elevation, and then all of a sudden they plummet. Your white counts will be, you'll have a leukocytopenia. And that is a sign of sepsis. That's a very ominous sign. And when I tell my story about, I can still remember this lady's name, the patient that we lost because of this preterm rupture membranes, you'll kind of get it a little bit more. We're going to administer corticosteroids. If we can keep mom pregnant for 24 to 48 hours, that's almost ideal because we'll get steroids on board. Now, typically, there are 2 protocols you use with steroids, which we'll talk about more with preterm labor. But just to get your feet wet, we give 1 dose of betamethasone. It goes IM into a deep muscle. And let me tell you, patients can point to it a month after. They get so sore from this. But you're going to look for a nice deep muscle, either your vastus lateralis or your ventrogluteal. This is not appropriate for a deltoid injection. And then either 12 or 24 hours later, you're going to give another one. A lot of doctors really prefer that 24-hour protocol. And if you can give mom some time to mount a response to those steroids, that baby's lungs will mature. And this is really important because if we have to deliver a 29-weeker, we want to give them every advantage we can not to go into respiratory distress syndrome because they will circle the drain if we don't try and get something on board for them. You're going to minimize the vag exams. Don't go sticking your fingers in there. Even with sterile gloves, even with sterile anything, mom has bacteria in her vagina, and if you're going deep in there to examine the cervix to see if she's dilated, you're going to introduce something into that sterile place. Now, obviously, if you're in labor and she's making progress or she's complaining she feels the baby's head, yeah, you have to do something, but you need to minimize this. That's what's going to help you prevent infection. And for GBS, now we haven't talked about GBS yet because that's really labor, so that's part of our interpartum content. But I will briefly touch on it, and you'll have a background then when we do talk about it. Group beta streptococcus is not really an infection per se. Most women who have it are asymptomatic. This is just a colonized bacteria. It's almost normal flora for them. And the numbers vary depending on, again, what you read. But it's anywhere from 1 in 5 to 1 in 3 women who have colonization with group beta strep. Now, it's not a problem for mom, but it can be a problem for the neonate if they acquire it during delivery. And so what we do is we treat it with penicillin during labor, unless mom's allergic, and then we try to find an agent that will work with a CNS. It's not as specific as syphilis with the penicillin, but penicillin is the preferred agent for treatment for group beta streptococcus. So those are the things that we would do medically to help prevent the risks of a preterm rupture of membranes. And of course, we're going to monitor the fetus. There is going to be electronic fetal monitoring. And when we talk more about electronic fetal monitoring, we're back to the 6 degrees of separation. There are certain things you see with cord compression that are very typical. And when you have somebody who's ruptured or somebody who's oligo for any other reason, it's not uncommon to see these variable decelerations. And as long as they recover from it, we wouldn't necessarily rush to delivery over a couple of variables, but we would want to see them and we would want to notify our provider if we saw them. Okay, so for nursing actions, you're going to monitor mom's temperature and other vital signs. If you have a mom who is getting septic, you'll see changes in vital signs. Hopefully it doesn't go that far. So if you have a temperature, and they'll usually give you the parameter of 100.4 or more, you should call and make sure that you're monitoring that at least every 2 to 4 hours, depending on where you work. And some places will want you to monitor every hour. I don't think I've ever been asked to go that far, but every 2 is not uncommon, and every 4 would be a bare minimum. So you're going to monitor mom's temperature, and you're going to look at her vital signs. If she gets tachycardic, we know we're cooking an infection. Of course, if she gets tachycardic and hypotensive, then we're really kind of worried because those are signs of shock. We're going to ask mom to report uterine tenderness, contractions, any foul odor, and we're going to look for those things as well. When you palpate the belly, make sure that she's not doubled over in pain. If she starts to feel really crampy, if there's an odor to that fluid, we want to know right away. We're going to monitor fetal heart tones. And typically you might see continuous monitoring, or you might see an hour Q shift or an NSTQ shift, but you're going to look, and like I said, you'll see changes if there's cord compression or if baby is otherwise not tolerating the environment. You'll see tachycardia if the baby has a fever, and don't worry about that right now. Hopefully it'll kind of sink in, and then we do talk about electronic fetal monitoring as a separate concept, and that'll be the next video that I make. Tachycardia is associated with fever. Variables are associated with cord compression. Those would be some things you'd want to know and report to your doctor. They might get the NST, and of course, what do we do if an NST is not reactive? Gee, I wonder if you'll ever see that again, a biophysical profile. And those are those parameters that we decide whether or not the baby is well oxygenated by looking at their activities, whether they're moving, whether they have good tone, whether they're having breathing efforts, what their fetal heart's doing, and how much fluid they have. So another thing that we want to do as nurses is educate mom. And one of the things we want to do is educate her about scrupulous hygiene, okay, we're also, while we're teaching her to report all these danger signs, we need to let her know that if she's not already wiping front to back, that is absolutely necessary. And instead of toilet paper, very often I will counsel moms to use the peri bottle, which is a little squirt bottle, and then to pat dry, always going from front to back, so that little pieces of toilet paper aren't left behind when they wipe that could possibly carry bacteria from the rectum into the vagina and up into the amniotic sac, and sort of fester and make infection there. So you also want to make sure that mom understands that nothing should go in the vagina, even if she's leaking fluid and she thinks it's gross. No tampons. Certainly she's not going to try and have sexual intercourse, anything like that. You really want to counsel her about the risks of infection. And we're also going to give her emotional support. Probably at this point, most moms aren't thinking that they're going to deliver so early. And so she's going to need emotional support. If we're anticipating a baby that's going to NICU, we want to get her hooked into a program. We want to get her maybe a consult with a neonatologist. If they have a family support program for the NICU, we would want to get her involved in that. If we could even give her a tour of the NICU so that it's not so intimidating and overwhelming when she does have to go see her baby. That's very helpful to moms. March of Dimes has great information that we've handed out to patients about what to expect in the NICU and what to expect your preterm baby to do over those first few weeks and months. So emotional support is important for the mom expecting a preterm baby. It is really, really crucial for the mom expecting not to take a baby home. So in those pre-viable cases where you're ruptured at 18, 19, 20, 22 weeks, at this point we are providing bereavement support. And that is a lecture you'll get, I think, from Kathy Donaldson, if we can get her to come speak to you. Bereavement support would be very important at this time. So that is our discussion of preterm rupture of membranes, and we'll move on. And I did promise you guys a story, so I'll tell it very quickly, and those of you who have already heard it from me in the context of DIC when you were covering hematology, I apologize for being repetitious or boring. You can kind of fast forward through it. But we had a patient who was actually one of our nurses on the floor. She was 43 years old, had infertility issues, finally got pregnant, went through an amniocentesis, and we're not entirely sure if that had anything to do with the fact that about a week later, while she was working on our antepartum unit, she ruptured membranes. So immediately, she told somebody what had happened, and we put her in a bed. And because she really, really wanted this pregnancy desperately, and she thought it was her last chance, she wanted to remain pregnant. She was only 19 weeks and some days. Well, at that point, there wasn't a really clearly defined protocol about what to do with the pre-viable mom. And people were experimenting with things. There was a glue that they were trying to develop at the university, I think it was Christiana maybe, with the University of Delaware, trying to sort of patch the amniotic membrane. And that project has since been discontinued. Anyway, so we got her in a room. We did antibiotics, and in addition to the ampicillin and erythromycin IV, I think she was given Clinda or Vanco or something crazy. But we were monitoring her temperature and her CBCs every day, and we started to see a little trend upwards. Not crazy high, but a little more this day, a little more that day. And finally they dropped precipitously. And her temperature, which had been climbing up, like 99.6, 99.8, that dropped to 94.5. They couldn't get it with one of the thermometers we had. They had to switch out the thermometers. So those are some things that happen with sepsis. So they went to deliver with a cytotech induction. And, when we talk about cytotech induction, there's an unpredictability to the action of that medication. We inserted it as a vaginal medication. You can give it PO now, but the protocol at that point in time, it was 2002 maybe, we were giving it intravaginally. And with every insertion of this medication, we were also doing a digital vag exam. So there was that danger. And I think they tried to induce her for the better part of the day. Well, she was septic. And again, this is maybe a 19 or maybe 20 weeks at the point where she actually delivered, but very pre-viable fetus. She started to hemorrhage. She went into DIC. So they took her to the OR on labor and delivery floor, which is mostly for C-sections. And they tried to do a D&E, which is hard when you've got a 20-week baby. They're, big enough that it causes a little bit of a problem getting the baby out in one piece. But they got the baby out, and they got the placenta out, and she just wouldn't stop bleeding. She was hemorrhaging massively. So they tried ligating the uterine artery. They tried, they were going to a hysterectomy. And this particular doc was very against unnecessary hysterectomy, unnecessary intervention. So she was more of that granola type. So this was serious. We knew they went through at least, I want to say, 17 units of packed red cells. And at that point, we also didn't have the massive transfusion protocol, which replaced the clotting factors. And so she was just pouring blood out of every orifice. And this happened very quickly. And I'm just telling you this because one day she was fine. She was normal. She had a 99.6 temperature, which we were concerned about, but not terrified. And she was stable. And the next day, she was septic and dead. And so those are, that's sort of where you are with preterm rupture of membranes. You don't want to take a risk, and you want to be really on your game watching these people because this is a cause of maternal death, potentially. There was another case in Ireland, and they considered a cytotech induction at 18 weeks with if you had a fetus with a heartbeat to be an abortion, and because abortion is illegal in that country, they would not perform a cytotech induction, and the woman became septic in a very similar scenario and also died. So that is what you need to remember about preterm rupture of membranes. All right. Moving on to our next topic, which is incompetent cervix or cervical insufficiency. This is defined as a mechanical defect in the cervix that causes a premature opening of the cervix. It is not preterm labor. Labor requires contractions. This is just a cervix that isn't strong enough to hold a pregnancy. There are some risk factors for incompetent cervix, although a lot of the cases of cervical insufficiency really have no known risk factors. It's something that's diagnosed after a repeated pregnancy loss. But one of the risk factors is, sorry, let me make that just a little bit bigger so you can see it. A history of cervical trauma, and by this, if you have multiple dilatation and curettage, either because of early prenatal loss or because of elective termination of pregnancy, you're more at risk because that cervix has been, the integrity of that cervix has been sort of breached a few times. LEAPS procedures or other procedures for abnormal pap smears. When you get cervical cancer, they will do like conization biopsies, different things that can weaken, again, the integrity of the cervix. Cervical lacerations, and these can happen during birth or they can happen as injuries. And precipitous labors, those very, very rapid labors where the baby sort of barrels through the cervix. So if you have a history of cervical trauma, you are at greater risk of developing incompetent cervix. DES daughters, I'm mentioning it because you might see reference to it on an ATI quiz or something like that, or a proctored exam. But the DES daughters really happened, let me see if I can find out what years. I want to say it was between, let me see if I can find it. 1938, here it is, 1938 and 1971. So if you do your math, you'll see that if it's 2016, the last generation of DES daughters, and I'll explain what DES is in a minute, is 45 years old. So you will be seeing fewer of these people. DES was an estrogen that I say like I was there, providers used to give to women to prevent miscarriage. And because they were desperate to maintain their pregnancies, they took it, and with no thought to what the consequences to their children might be. And because the abnormalities that were noted were of the genital tracts of these women, they really weren't spotted until they became old enough to bear children themselves, and people almost laughed at the idea that these abnormalities could have anything to do with it. But when they studied it, the risk for DES daughters was greater than 60% of having a major abnormality of the vagina, uterus, cervix, any of the female reproductive organs. And so you'll probably still see some reference to DES daughters. Third generation DES survivors have not had any increased risk as far as the women go. Male offspring of DES daughters do have a higher incidence of some male reproductive disorders, but it is technically a risk factor for incompetent cervix, and if you have that 45 or 46 or 47-year-old pregnant woman, God bless you, she is at risk for incompetent cervix. Then we have congenital structural defects of the uterus or cervix. These are people with the bicornuate uterus. They have like two horns where the uterus is just oddly shaped. You can have a T-shaped uterus, but some abnormality of the uterus or cervix predisposes you. Again, most women that have incompetent cervix really didn't have any risk factors. It was something that was diagnosed when they had multiple pregnancy losses. And generally when they got to be 12, 13, 14 weeks, somewhere in that early second trimester is when they would have their loss. So what does incompetent cervix look, feel, sound like when you see it in a patient? Subjective data, patient reports increased pelvic pressure, and they might have some increased vaginal discharge. Generally, the membranes are intact and the fetus is alive, but you will eventually get ballooning of the membranes. They'll sort of bulge, they'll hourglass out of that cervix. Let me see if I can find a picture of an incompetent cervix for you, and that might help you visualize what this looks like. So, yep, here we are. Okay, you have your normal length cervix on the left, and it should have a pretty good length to it and thickness. and there should be no bulging of the membranes. When you get to the incompetent cervix, it gets shorter. There is dilatation, and sometimes there's what we call funneling, where the internal os is more dilated than the external os. So that's something you can see with incompetent cervix. So the objective data, how do we kind of diagnose an incompetent cervix? As I said, most of the time we diagnose it after the fact, but there is now an emphasis on transcervical ultrasound. Oh boy, sorry. Where they will measure cervical length, and they can see things like funneling. It would be like a vaginal probe, and you would get that picture. There was a study done in 2010 at Jefferson when I was getting care there, and they kind of had me sign up for it. They were looking to see if they identified women who are at risk for incompetent cervix and preterm labor with transcervical ultrasound, and what they found was there was really no benefit to routine screening for incompetent cervix. They are looking more at whether women who have shortened cervix with funneling or whatever could benefit from progesterone administration to prevent preterm labor, and that so far has looked more promising. Physical assessment, if somebody has an incompetent cervix, how will they present to the doctor or to the emergency room? They'll have pink tinged, that little bit of bleeding when the cervix starts to open, those little capillaries kind of burst. So pink tinged, mucoid discharge. I'll leave that autocorrect, it's not bothering me that much. They could get a rupture of membranes. Now, if that bag, that amniotic sac sort of pokes through the cervix, you will get an hourglass-shaped bulging bag, and that, obviously that increases your risk for preterm rupture of membranes. And if this is a pre-viable pregnancy, remember, there's really not a lot you can do about that. You can get uterine contractions. That would be your preterm labor with expulsion of the fetus. So that can happen. So these are some things, but most of the time what you're going to find is recurrent second trimester loss. When a woman has a second trimester loss, it's very uncommon actually to lose your pregnancy that late in. And so whenever there is that loss at 16 or 18 weeks, they really have a high index of suspicion for incompetent cervix. And if it happens more than once, almost certainly they're going to be recommended for the treatment for that, which is, hold on, cerclage. Let me respell that. Really not loving this feature because it didn't used to happen. It's an update. But cerclage is a suture that goes around the cervix. And I'm going to get you a picture of it. Just give me 1 minute. Our last topic for today is going to be multiple gestations. Twins and higher order multiples are not abnormal per se, but they do raise the risk for complications of pregnancy. And so we're going to talk about multiples as part of pregnancy at risk. There are two basic ways that we see multiples. We have dizygotic twins or higher order. You could have triplets or whatever. Basically, these are two separate pregnancies occurring at the same time. You have release of two ovums. They are each penetrated by a different sperm, and you get two individual people with different DNA. You can have monozygotic twins. And monozygotic twins start out as one fertilized ovum, one zygote. That's how you know. Mono means one. Zygote means, zygote is what it means. You have the fertilized ovum. At some point early on in cell division, it splits off and becomes two individuals with the same genetic makeup. And this is thought to occur partially as a risk when you have damaged ovum or a damaged zygote. A lot of times infertility will yield both identicals and fraternals. Fraternals because you're stimulating ovarian hormones and you can release more than one egg. And monozygotic twins, because sometimes if you're using especially IVF or pregnancies like that, the ovum is somewhat damaged and it can split off into two separate individuals. Okay, so that's the difference between dizygotic and monozygotic. When you have higher order multiples, such as triplets, quads, you can have monozygotic twins with a singleton. You can have two sets of monozygotic twins. We had that situation about 5 or 6 years ago. It's very uncommon. I think the chances were like 1 in 3 billion, but there were two sets of identical twins. So you can have almost any configuration. And it's important to note that that monozygotic twins have a much higher incidence of problems than dizygotic twins, and we'll sort of explore that next when we talk about what happens with the placenta in multiple pregnancy. There are variations, and we're going to talk about them. I'm going to give you a little picture because I think that'll explain it the best way. Here it is. Okay, so we have on the left dichorionic, meaning two placentas. Here, let's move that a little bit, and we'll say so if you're worried about whether it's dichorionic or monochorionic, it's how many placentas. That's what we're worried about. Okay, and chorion is relating to the placenta, right? Okay, so then we have amniotic. And this relates to how many amniotic sacs. Okay, so if you have dizygotic twins, you'll always have di-di configuration. They will have separate everything. They are separate pregnancies in one uterus at one time, but they are completely separate pregnancies. Each fetus has its own placenta. Each fetus has its own sac. Okay, so let me circle it for you and you can see exactly what I'm talking about. That is your di-di. Identicals can also have di-di configuration, but fraternals always have it. Okay, so that's your di-di. You can have, and all of these any other variation is always an identical pregnancy, always a monozygotic pregnancy. When you have identical twins, you can have a monochorionic, diamniotic, which is also known as monodi. I'm guessing this is going to be a muddy point for some of you. But if you have one placenta, you can still have two sacs. And this is a riskier situation because you have two babies feeding off one placenta. It would be like two people trying to breathe off of one set of lungs. You could probably do it, but you would have to work harder at it. So a di-di twin who has its own circulation and its own separate little house is in a good position. A monochorionic situation requires a little more effort and has a little more risk because they're sharing that blood supply. Okay? Now you have the scariest situation, which is your monochorionic, monoamniotic. Okay? There is one amniotic sac, there is one placenta. Okay, so now you have twins, and I want you to take a really good look. I'm going to blow this picture up, and I want you to see what's happening with those umbilical cords. Okay, in a diamniotic pregnancy, the umbilical cords never wrap around each other, but in a mono pregnancy, they can. Okay, and so you have an increased incidence of cord accidents. Another thing that creates the risk factor in a mono pregnancy, and it can happen in a mono-di pregnancy, but more commonly in a mono pregnancy. These are, again, identical twins, sharing a sac, sharing a placenta. You can get what's called a twin-to-twin transfusion, where one twin acts as a donor and the other acts as a recipient. Okay, and we'll talk about that a little bit in more detail when we talk about the risks to mom and baby of having a multiple gestation. So I put a big long list of stuff that can go wrong with multiples, and now you see it's like, yeah, the twins in themselves are not really an abnormality, but look at all of the things that can go wrong. You have a greatly increased risk of preterm labor, especially with your higher order multiples. Each additional pregnancy takes about 3 weeks off the length of gestation. And so if you would normally deliver at 39 weeks, now you're looking at 36. And that's on average, because some twins will be delivered at 24 weeks, and some will be delivered at 28 weeks, and some will be delivered at 32 weeks. But preterm labor and preterm delivery are definitely a major risk with multiple pregnancy. Preterm rupture of membranes is another risk. Again, you've got hyperdistension, particularly when you have one amniotic sac. You can have that preterm rupture of membranes, and that can end up being a prolonged thing, and your risk for infection goes up. The risk for preeclampsia and hypertension is dramatically increased. And again, I think if you go back to the video where we talked about the reason that we get preeclampsia, anything that increases the complexity or the size of that placenta is going to impact on the modeling of those spiral arteries, and so you have a greater risk for preeclampsia with multiple pregnancy. Gestational diabetes is also a risk, and that again is related to the amount of hormones that are released by the placenta. You have two placentas or one big one. It's putting out a lot more of those insulin antagonizing hormones, such as HPL or insulinase. Anemia and other vitamin deficiencies. You know, the babies are taking nutrients from mom, so her risk for anemia goes way up. She's going to look more anemic too, because her blood volume goes up 50 to 60% by term, which is another 500 cc's or mLs. Sorry, we shouldn't be using cc's, but another additional 500 mLs of blood volume compared with a singleton gestation. So this mom is 50 to 60% higher, and her red blood cells might still only be 30%. So she's going to look more anemic, and she's going to be more anemic. Okay, so there's that. Postpartum hemorrhage, because you have this over distension of the uterus. Remember that rubber band, you pull it and pull it and pull it. Eventually, when you want it to snap back, it might or it might not. And so we have an additional risk factor for postpartum hemorrhage. We have a risk factor for placental abruption. The risk for placental abruption is higher in your multiple gestations. We have a risk, mom has a risk, and let's annotate this, that this is a maternal risk. The babies have other risks, but the maternal risk for maternal pulmonary edema and cardiomyopathy is related to the increase in fluid volume and the workload on the heart. So that risk increases. We have an increased risk for cesarean birth, and some of this is due to the fact that multiples generally get in all these different configurations. They're not always vertex, and it's harder to deliver babies that are not in vertex position. I have seen them attempt vaginal delivery many times when baby A is vertex and baby B is some variation of transverse breech, whatever, because their feeling is that if baby A is vertex and the head is the biggest circumference, there will be enough room to deliver the rest of the baby. And so they will attempt it. However, anything can happen, and I have seen situations where mom gives birth vaginally to baby A, and then baby B has to be a cesarean, and that's, almost cruel, because now she's got to recover. She had to go through labor, she had to go through vaginal delivery, and now she's got to recover from both of those events on top of surgery. We see in the fetuses, a risk of intrauterine growth retardation, also known as IUGR. That is what that abbreviation stands for. We've talked about it before. IUGR and discordant growth. And this is where we see that twin-to-twin transfusion. One baby gets real big at the expense of the other baby. Much more common in monozygotic twins, your identicals. IUGR can happen in any multiple pregnancy only because one mom, two babies, or more babies, and they're trying to share a blood supply. So you'll get a smaller baby even for the gestational age. So now you're looking at a preterm baby who's even smaller than it would be, usually. You have a higher risk of intrauterine fetal demise. That's what that IUFD stands for. And let me spell that out. Okay, and intrauterine fetal demise is especially likely, well, like I said, when you have those mono twins. and their cords can get tangled up in each other. Cord accident is the most common complication there. You can sometimes get an early loss where the first twin demises in utero, has spontaneous abortion for whatever reason, and mom continues the pregnancy to full term with the remaining baby. And we have had the situation where we have delivered the second twin stillbirth, for many months, and the first twin as a living baby. And that's always an interesting situation because mom usually only wants to focus on the healthy baby, which is appropriate. And then we see low birth weight, so your SGA babies are small for gestational age. And we just talked about that with IUGR. The big difference is that IUGR is when they're still in utero, and small for gestational age is when they're born. So those are all the risks to the pregnancy. So the way that the perinatal team will generally manage a pregnancy complicated by multiple gestation is just to increase the surveillance. We're going to see a lot of serial ultrasounds for growth. And then all of the things that we monitor every pregnancy for, we're going to do in this mom just more often. So monitor for preterm labor, and you as the nurse are going to be the person who educates this mom about what to look for. Any vaginal leaking, any vaginal bleeding, any contractions, mom needs to know that she needs to call her provider, and she needs to know that sometimes preterm labor doesn't look like classical labor in a full-term gestation. It could be a backache, it could be thigh ache, she could just not feel good, she feels unwell. Those are things that need to be reported to the provider immediately. Certainly if she is having contractions that are more than once every 10 minutes and they're lasting longer than those little Braxton Hicks sort of spasms, she needs to report them. And all of the management that you would do for preterm labor, which we're talking about with labor, you're going to do for this mom as well. Okay. In terms of that also, I just want to say one thing. Cerclage in a multiple pregnancy has not been associated with better fetal outcomes unless mom already has a history of incompetent cervix, and this just happens to be multiple gestation. In fact, the risk of preterm rupture membrane and subsequent infection is higher. So cerclage has really not shown any good benefit as far as prophylaxis for preterm delivery. We're going to monitor as baby gets a little older, NST, BPP. And that gets to be a little bit interesting because sometimes we have a situation where baby A does fabulous and baby B not so great. But they'll make decisions based on the BPP of both babies. And certainly if either of them looks to be in distress, they're going to opt for delivery. Monitor mom for all the complications, so our hypertension, all the hypertensive disorders, gestational hypertension or preeclampsia. So that would be part of your routine care. You would certainly want to teach mom all about that headache and the epigastric pain and the blurred vision and nausea and vomiting later in pregnancy, which are not normal. They are a sign of PIH. We're going to monitor for gestational diabetes. Again, you got 2 placentas or even one big one putting out lots and lots of insulin antagonists. We may have to screen her more than once. And we're going to monitor, we'll teach mom fetal kit counts. Any type of decreased movement in pregnancy, fetal movement, needs to be monitored very carefully. So as far as antepartum management, that's really where we go. When we talk about intrapartum management of multiples, we're really talking about twins because it's very uncommon to deliver triplets, quads, anything more than twins vaginally. That's usually going to be a scheduled cesarean or even, sort of a stat cesarean if they walk in and they're already in labor or they're already ruptured. So really, when we're doing labor management with a multiple, we're talking about twins, and the standard of care is continuous electronic fetal monitoring. So both babies have to be on at the same time. You can't monitor one and then the other. You have to have both babies. And even if you're antepartum, you've got twin mom there for some other reason, if you're even just doing a fetal heart check, make sure that you have a good period of time where you are monitoring 2 separate heartbeats, and if at all possible, throw a pulse ox on mom that reads out on the monitor so you know you have 2 babies and a mom, and all patients are accounted for. So along with that, we have to make sure that your OB has to be in-house when your twins are here. They can't be managing from home because we need to make sure we have access to cesarean birth. Even if our plan is a vaginal delivery and both babies are vertex, we need to make sure this turns into a cesarean birth fairly often. So we should have all of that immediately available, and that means that anesthesia has to be in-house, the OB has to be in-house, we have to have a circulator, we have to have a scrub, we have to have NICU involvement, so neonatal. Even if we're dealing with twins that are, term and of a good size, the neonatal team must be available. Okay? All right. So it's a big party when you have a cesarean birth for twins, or even if you have a vaginal delivery. We always deliver them where I work in the OR. We don't ever deliver them in the room unless it's something that we didn't anticipate properly. So we always do that in the OR because sometimes baby A comes right out and is born vaginally and looks great, and then baby B gets us in trouble. There's, a tangled cord or a prolapse or something, and we can't deliver that baby vaginally, or they're stuck. Sometimes a provider will go in if that baby's real transverse and try to turn the baby into a vertex or even into a frank reach, which is buttocks first, and it doesn't happen, and so you end up in a situation where you have to do an emergency cesarean, and you have to do it like right now. So all of that has to be available. We have to have agents available for postpartum hemorrhage. Now, almost every hospital that has a labor and delivery unit, I'm going to say, without having surveyed them officially, has like a postpartum hemorrhage kit. Oh, sorry, I didn't put the word hemorrhage there. My bad. Okay, so you need to have your methergin, your oxytocin, your hemobate, all of those things, Cytotec, all those things should be readily available. We have a kit. You go into the cart and it's right there, and you pull it and you are good to go. Those are the medical agents. We also, when we're going to deliver twins, we deliver them in an OR. We have several ORs at Capitol, and the one that we usually use always has is equipped with the balloons, the Bacri balloons that we use, and suture for B-limb suture. It's something you'll learn about in postpartum, but you need to be ready for that because they are at risk. And you also have to have a type and screen. Now, mom, type and screen can be no more than 72 hours old where I am. So you need to be able to get blood products really, really quickly. So that is really how we manage labor with your multiples. And again, we're talking really about twins, because if you have triplets or anything else, I don't know anywhere where they wouldn't schedule a cesarean or perform one if labor happened before it was scheduled. Okay, so short and sweet, the nursing responsibilities in the context of multiple gestation is just teaching mom what's normal and what's not normal. You'd be surprised at how many people think a little bleeding in pregnancy is normal, or the babies are real quiet today because they're running out of room. They're 37 weeks. They don't have any room to kick anymore. They need to know the warning signs of preterm labor, the warning signs of preterm rupture of membranes. They need to know warning signs of preeclampsia. They need to know decreased fetal movement is an ominous sign. So all of that teaching that goes along with it. They need teaching about nutrition. They're going to need an additional 300 calories on top of the additional 300, so like 600 extra calories a day to maintain weight. We're going to need to tell them that they need to gain at least, in a normal pregnancy, 35 to 45 pounds instead of that 25 to 35. And then the other nursing responsibility, when you're monitoring babies, either with a Doppler or with an electronic fetal monitor. You make sure that you can account for all your babies at the same time. You're taking attendance. Don't let them fool you. Don't do one and then do the other and say, well, they were in a different spot, because really, wherever you angle that ultrasound, you could get an echo somewhere. So make sure that you can account for all fetuses simultaneously, and the best way also is to make sure that you don't have either one of them as mom's pulse. Particularly if mom goes through labor, she gets a little bit tacky, you can have a lot of signal ambiguity. So make sure that you take attendance and you've got everybody present and accounted for. And the other nursing responsibility, you're going to collaborate with your NICU, your neonatal team. If they have the NICU family support program, definitely get somebody over there to talk to mom, because she's probably looking, if she delivers prematurely, at some length of time with the NICU. You're going to want to get her involved with social work if you can, to see if she needs extra services. And you're going to make sure that you're in frequent contact with the perinatal team, and that your docs who are managing this patient know what's going on if this is an antepartum patient. And that is the end of part 4, odds and ends. There are other topics that we could discuss, but to be very honest, we only had 5 or 6 hours allotted for this unit, and I think what you have is more than enough. Okay.